Uh, Good afternoon, everybody. On behalf of the Department of Pulmonary Critical Care and Sleep Medicine, we welcome you to this clinical combined round today. The topic is where there is a bronchoscope, there is a way, and I'll just give you a background why this is so, and of course, we'll discuss later. Basically, what in the last 10 years or so, if one intervention has kind of really revolutionized the diagnostics in respiratory medicine, it would be the endobronchial ultrasound. And that now really has made our reach very wide into the mediastinum. We are able to sample mediastinal structures and have a very high diagnostic yield. Now, as experience grows, then people obviously try to then innovate. They try new things. They try to go deeper into it to expand their kind of scope, and they go into many unusual lesions. So, a lot of literature and a lot of things have happened as far as this particular technique is concerned. When we started doing all this, we have done more than 3,000, 4,000 procedures till now. And while doing this, obviously, it is a scope which goes in the trachea. So it is a bronchoscopy. There is some respiratory distress, and it's a slightly long procedure. We found that obviously when we go into the trachea, there are problems of breathing, especially in borderline patients who may be hypoxic, intolerant. So then we try to do things in a slightly different way and try to go into the esophagus and try to do sampling and all from there. So that is something that we are going to try and tell you how we managed to do things in a different manner using what we had at our disposal and how we were able to achieve a good diagnosis. With this, I'll just call upon my senior resident, Dr. Anurachalam, to talk about the case, and Dr. Rohit to discuss the review of literature pertaining to it. Thank you.
Thank you, sir. Good afternoon to all. I start up with the case history. He is a 48 years old gentleman, married, resident of Faridabad. He is a reformed smoker with a smoking history of 400 and cook by occupation. He presented to us with the chief complaints of low backache for 2 months, which worsened over the last 15 days, and dry cough for 2 months. And he also has shortness of breath for a month and loss of appetite and loss of weight. Apart from this, he doesn't have any significant positive presenting complaints, and in the past medical history, he is a known case of diabetes mellitus for 5 years, and he is controlled with oral hypoglycemic agents, and no other significant past medical history. On general physical examination, patient is conscious, oriented, he has a clubbing of grade 2 degree, and his vitals are stable, and he maintains a saturation of 96% on room air. And on respiratory system examination, trachea in the center, barrel-shaped chest is noted, bilateral diminished breath sound on both sides and no added sounds, and other systemic examination were unremarkable. This is the chest X-ray of this patient, posterior anterior view, which shows a left mid-zone and lower zone paracardiac heterogeneous opacity, and this is the contrast enhanced CT thorax of this patient, which shows the well-defined mass lesion in the left lower lobe, which measures in the maximum diameter less than 5 centimeter. And also we can able to see the heterogeneously enhanced paratracheal lymph nodes, subcarinal lymph nodes, and in the lower cut we can able to see a enlarged left adrenal gland here. And there is no pleural effusion or pericardial effusion, and there is no bony lesion. And with this, the case summary is a 48 years old male patient, smoker with complaints of low backache, dry cough, shortness of breath, loss of weight, and loss of appetite. On clinical examination was suggestive of COPD. Radiology showed a left lower lobe lung mass with mediastinal lymphadenopathy and left adrenal enlargement. With this finding, the most likely first differential diagnosis is carcinoma lung with possible left adrenal metastasis and COPD, which comes in a clinical stage of T2, N3, M1B, and the other less likely differentials would be disseminated tuberculosis, disseminated extrathoracic malignancy, and disseminated fungal infection. So, considering our first DD bronchogenic carcinoma, how do we proceed further for diagnostic and staging of a bronchogenic carcinoma? This is the principles of lung cancer evaluation says, contrast enhanced CT chest and upper abdomen including adrenal as the first investigation of choice, and diagnosis and staging should be done with the least number of investigation with least risk of complication. So the aim is to identify the site of biopsy which has the highest stage of the disease, and this site which we plan should also be technically feasible. And the sample we obtain should be adequate enough for histopathology, IHC and molecular markers, as nowadays targeted therapy is the treatment of choice. So in our case, it requires adrenal and mediastinal lymph node evaluation, and the adrenal is the highest level of lesion in our case, and the possible approaches to do it are image-guided adrenal sampling, by which we can get a sample from the adrenal gland, but in case if it turns to be negative, patient needs to re-undergo a procedure, or he needs to undergo a separate procedure for a mediastinal lymph node sampling. Or the second procedure what we have in hand is endosonographic approach for left adrenal gland. By this procedure, we can sample the adrenal gland, and at the same sitting we can able to sample the mediastinal nodes also. So nowadays, the management of lung cancer, the EBUS centered strategy is the preferred modality. What is EBUS? EBUS is an endobronchial ultrasound. This is a bronchoscope. At the distal tip, we can have a dedicated ultrasonographic probe, which allows to do as a real-time sampling. In this image, we can able to see the needle through the working channel. With this, we can have a real-time imaging of the sampling. And EBUS centered strategy has shown in RCT that it decreases the time to treatment decision compared with usual procedures. So this EBUS scope is introduced through the tracheobronchial tree, and by which we can able to sample the upper paratracheal, lower paratracheal, hilar, subcarinal, interlobar lymph nodes, whereas we can't sample the esophageal pulmonary ligament or a lesion in the liver or the left adrenal gland by this EBUS procedure, for which we need to introduce the EBUS scope through the esophagus to sample such lesions such as esophageal, parahilar, or the liver lesion or the left adrenal gland. This procedure is called as EUSB. EUSB is esophageal ultrasound with ultrasound bronchoscope. It is nothing but introduction of the EBUS scope through the mouth into the esophagus and scanning the mediastinal structure and the left adrenal gland. So in our case, EUSB FNA we did for the left adrenal gland and mediastinal lymph node in the same sitting. The procedural details: patient under conscious sedation and tropical anesthesia, patient in supine position with supplementary nasal oxygen. EBUS scope is inserted via the oral route and passed into the esophagus. Left adrenal gland is identified. 3 passes were taken and ROSE was performed. In the same sitting, subcarinal lymph node was identified. 2 passes was taken and ROSE was performed. This is the EUSB image, sonographic image of the left adrenal gland, which is enlarged here, well-defined borders, and this is the image which shows the during the sampling technique. This is the needle which is inside the left adrenal gland. This is the similar image of the enlarged subcarinal lymph node during the sampling procedure. This is a video which shows during the sampling procedure EUS scope into the esophagus, and first we used to identify the liver, followed by retrogradely we used to identify in the left side we used to identify a glandular structure which is the adrenal gland. This is during the procedure. This is jabbing of the lymph node with the 22 gauge EBUS needle. Histopathology. I request Dr. Vandana from pathology senior resident to describe the histopathology.
Good afternoon, everyone. We received cytology smears from both. The adrenal gland lesion as well as the subcarinal lymph node, both of which showed similar tumor. On the left hand side, what we are seeing here is a photomicrograph of an alcohol fixed Papinicolau stain smear, which is showing a highly cellular smear here, which is composed of monomorphic tumor cells. This inset here shows a higher magnification of the same slide. Here we can see that these tumor cells, these are small size tumor cells which have very scant amount of cytoplasm and a high nucleocytoplasmic ratio with the salt and pepper chromatin. Also, what we can see here is a strand of this blue colored nuclear material which is going through this through the nucleus of this tumor cell. This is called as nuclear streaking, which is a feature of small cell carcinoma. On the right hand side, what we are seeing in the low power is the air dried Giemsa stain smear, which was from the subcarinal lymph node. Here we can see similar population of tumor cells. On higher power, here we can see that these tumor cells are showing nuclear molding. Like these two tumor cells, the walls of these tumor cells are molding into each other. They are shaping each other's wall. This is also a feature of small cell carcinoma. This is a photomicrograph of the float core biopsy, which was received from the left adrenal mass. This was formalin fixed, and here we can see on lower power, these are all the tumor cells, and like the islands of the tumor cells. On higher power, here we can see tumor cells which are showing similar features. This is nuclear molding with hyperchromatic nucleus and scanned cytoplasm and very high nucleocytoplasmic ratio. In few of the cells, we can appreciate the salt and pepper chromatin. Immunohistochemical stains were done, and the tumor cells showed dot-like positivity for cytokeratin. They were positive for TTF1 and INSM1. INSM1 is a neuroendocrine marker, and the tumor cells showed loss of immunoexpression of retinoblastoma, which is also seen in small cell carcinomas. So the final diagnosis which was made was of metastatic small cell carcinoma to the adrenal gland and subcarinal lymph.
Thank you. The final diagnosis is metastatic small cell carcinoma of the lung. I request my colleague Dr. Rohit to present the review of it.
Good afternoon all. So as we have seen from the case report, we will be reviewing the literature of use of endobronchial ultrasound, which is EBUS scope, which has been introduced via esophagus, which is known as USB, as we can see in this diagram. So before going ahead, just would like to show you the images. This is a EBUS scope which we have, which we use it in our scopy suite. And this is the conventional EUS, endoscopic ultrasound, which is used by the gastroenterologist. So we can see that it is almost half the size. It is a thinner scope with an ultrasound probe, dedicated ultrasound probe. And this is a shorter scope, around 60 centimeter in length, compared to the sophisticated endoscope, which is used by gastroenterologists. So when we insert the endobronchial ultrasound EBUS scope through the esophagus is a collapsible structure. So a good knowledge of medicinal anatomy is essential to identify the structure so that we can sample them. So once the scope is inserted through the esophagus, we first identify the liver, which is seen here. And then just at the opposite, once we turn the scope towards the left side, we can identify the left adrenal gland, which is seen here as a seagull shaped, as shown in this diagram as well. And once we identify, we can pull the scope up, and based on the vascular anatomy, we can identify the lesions, and it can sample the lesions, especially subcarinal lymph node and the foral paratracheal lymph nodes. So EUSB was first described in 2009, which improved accessibility to transesophageal structures safely. It can be performed under conscious sedation by pulmonologist and is possibly more comfortable to the patient. The usefulness of EUSB has been described in lung cancer staging, and it has also been seen that combined EBUS and EUSB-FNA have higher accuracy for diagnosing lung cancer and as well as staging. So coming to the indications of EUSB, it is used to sample mediastinal lymph node lesion, which is especially pretracheal lymph nodes, 4L. These are autopulmonary, subcarinal lymph node, and paraesophageal lymph nodes. In this, we can see that 4L and 7 lymph nodes can also be attempted via EBUS endobronchial route as well. So EUSB has also been used to sample paraesophageal abnormalities, and in patients with respiratory distress when endotracheal approach may be risky. EUSB has shown that it is more comfortable. Medicinal pathology in critically ill or intubated patients, EUSB can be performed. It has been also been used to sample and drain mediastinal cyst, and also it has been used to sample left adrenal gland as well. So this was the first case report from our department in 2015, which highlighted that EUSB can be safely performed and it is feasible in as young as 3-year-old child with mediastinal lymphadenopathy, which was done under moderate sedation with no procedural complications. This was a large systematic review and meta-analysis looking at utility and safety of endoscopic ultrasound with bronchoscope, which showed that overall diagnostic yield when EUSB was combined with EBUS, the yield was significantly higher than EBUS TBNA alone, and that additional diagnostic gain of EUSB over EBUS TBNA was 7.6%, and there was no serious complication noted during the procedure. So combining EBUS and EUS is an effective and safe method which is superior to EBUS TBNA alone in the diagnosing mediastinal lymphadenopathy. And this was a pilot RCT which was undertaken from our department, which has been published in 2020, wherein it looked at the diagnostic yield between EBUS TBNA and EUSB FNA for a mediastinal lymph node, which can be for mediastinal lymph node stations, which can be sampled by either approach. And we found out that the sample adequacy and diagnostic yield were equal in both these groups. So EUSB FNA as compared to EBUS TBNA provided similar diagnostic yield. So moving further, EBUS has an overall better and wider reach in mediastinal lymph node sampling compared with EUSB. So why did we sample adrenal gland? Adrenal gland, as we know, that it is the fourth most common metastatic site, followed by after lung, liver, and bones. And there is prevalence of incidentalomas, which can be seen in up to 5% on radio imaging, which are mostly benign. And there is no gold standard imaging modality to distinguish malignant from benign adrenal masses with 100% confidence. And solitary metastatic sites should be sampled for histological confirmation. So the adrenal sampling can be done with image-guided percutaneous biopsy, which is CT or USG guided, or a conventional US by a gastroenterologist, or an esophageal ultrasound with ultrasound bronchoscope, which is USB, which has been done in this case. So adrenal sampling, image-guided adrenal sampling has been traditionally been the modality of choice. However, there are cases that in up to 14% of patients it is non-diagnostic, and it can be associated with adverse event in as high as 12%, with predominantly hematoma and pneumothorax can be caused. And US FNA of adrenal gland is minimally invasive alternative to sample adrenal gland with 100% adequacy with no major complications. So this was a multi-center study which looked at which compared US BFNA versus the conventional US FNA for left adrenal gland analysis, and it showed that the left adrenal gland analysis by US showed a similar high success rate as compared to conventional US. And this was the largest cohort study on use of USB for left adrenal gland sampling in lung cancer patients. About 135 patients were enrolled, and sample adequacy was noted in about 87% with no procedural complications. So USB FNA for left adrenal gland is a safe and feasible procedure. However, it can be used in staging purposes with lung cancer and suspicious left adrenal gland. So there was no serious complications reported with use of USB FNA on reviewing all the literature. So our experience with USB FNA for left adrenal gland. So 3 patients with suspect lung CA and adrenal gland enlargement underwent EUSB procedure under conscious sedation. All the patients tolerated the procedure well with no complications. So to conclude, EUSB is complementary to EBUS and has been integrated into diagnostic armamentarium of intervention pulmonology. Left adrenal gland sampling in lung cancer patients can be performed easily and safely using EUSB. And this technique is useful for appropriate staging and diagnosis of lung cancer. However, it must be performed only by trained interventional pulmonologists in select cases. Thank you.
Thank you, Rohit. I actually messaged a lot of my gastroenterology friends, but no one is here. We are taking over their work, but I think they'll not be having a problem. So what this case basically highlighted is that the EBUS scope, which is a thin scope, can be passed into the esophagus, and it is being widely performed in the pediatrics department also now, because it's a kind of a more comfortable way to approach mediastinal lymph nodes. The issues with USB FNA are that although it's comfortable, it does not provide a wide reach for all these stations because it's a straight tube. So whatever is in the center is what you can approach. And what is also in the literature is that once you start from the liver, there's literature on liver sampling and celiac node sampling also with USB. So I think that is one way in which the the scope of the EBUS bronchoscope is actually progressing and widening. So this is an approach we've shown for lung cancer, but that might hold true for any adrenal lesion on the left side. So the bottom line message which we want to give is that the EBUS bronchoscope can be used through the esophagus to comfortably sample the centrally located lymph nodes. And if you go into the subdiaphragmatic location, you can sample the liver the celiac nodes, and also the left adrenal gland. Now, what is left is the right adrenal gland. So, there are a couple of reports that if you advance your scope further into a transduodenal approach, so that is if the gastroenterologist can do that, then they can approach the right adrenal, but the complication risk and the yield is inferior. So, for the right adrenal, the radiologist, the image-guided biopsy is superior. So this is the message we wanted to highlight from this case, and this might have applications into other adrenal lesions evaluations as well. So we welcome any questions or comments from.
Congratulations. Always good to hear about especially since you mentioned, and these things we done with so they add something that the plan seems like you have almost is it better than using a design for this?
So that's a very important question, sir. Nicely pointed out. So we are not doing anything more than what a gastroenterologist can do. And I would also not saying that this scope is doing a better job at what a gastroscope can do, because the gastroscope is actually, it's a larger scope. You get more of equipment, more of ultrasound quality and optics, and more of maneuverability. But that said, the sampling for any significantly enlarged node or a lesion can be equally easily performed by this approach. So what the bottom line is that if you have a straightforward lesion sampling, say a large subcranial lymph node, left paratracheal lymph node, or a large adrenal, the EBUS bronchoscope introduced by a pulmonologist into the esophagus can perform, as equally for a diagnostic intent as the USO, and we have data to support that. So in which the data of left adrenal sampling by a gastroenterologist versus pulmonologist was compared, the yield data was.
Yield actually is let me say, is similar. Only one advantage to the thinner size of the, that is one. And the other thing is the same sitting, we can access other nodes in the mediastinum, which might help us to diagnose and stage the disease further. Suppose the adrenal comes out to be negative, but if we have the mediastinum go to the contralateral side, mediastinum go to the right side, we can do that in the same sitting. That is one advantage.
And other example is that there is no control. This is something that will help in your department. Get to the point and then get it done. And that is
probably that is the most important thing, that this is for lung cancer. Most often it is for patients with lung cancer. So we gradually present with other. So for the staging purposes, when the patient comes for diagnosis, it can be done rather than getting a yes or no. The basic purpose of lung
That initially laboratory testing for you for the 20% of I think most of the and in that sense,
Yes, sir. So I think the message which we want to give is very clear. This is left adrenal sampling in the setting of evaluation of lung cancer. So, in which we have a pretest probability of this being an adrenal involvement with lung cancer, in which we are, going in. We are not actually, promoting it as an upfront modality for adrenal evaluation. But that said, if a clinician has evaluated the adrenal lesion and now, based after the biochemical investigation, wants an adrenal sampling, this is an approach which may be extended to left adrenal sampling for maybe other etiologies also.
we perform both deeper and POS, and there is the internal side to the scope. That is 6.9 millimeter lateral. So that is very difficult part of the process in children below 8 to 10 years age, and they are more active. So that's why we prefer more in the younger patients that have cranial lobe to the esophagus, and we learn from them only to the assembly. We are more comfortable in doing a EUSD sampling in focus cranial lobe in children below 8 to 10 years of age, and above that we go to the task. Where the size matters. That's why we are able to really get
So in the future, we may get similar ecoscopes.
already there.
So, a very good afternoon, sir. I am Dr. Raja Tiwari, and on behalf of the Department of Plastic Surgery, I welcome you all to our combined clinical rounds. And today we are presenting a very landmark case because today we are presenting a journey of an adopted hand. Adopted hand because this hand was completely separated from the forearm. The forearm was completely crushed. And today we will tell you the journey how we went through multiple stages in reconstructing a fully functional forearm. So without further ado, I would like to welcome Dr. Yash, Senior Resident in our department, to present this case.
Very good afternoon, everyone. So we are presenting a case of journey of an adopted hand. Such title because the hand was adopted by the leg from the forearm, and this was the first case in the world of its kind. So following are the patient details. Our patient was 25-year-old gentleman, factory worker and left hand dominant. He had an accidental injury to left forearm from a pressing machine. Basically, this machine is being used to make the hardware, where the hard metals being pressed between the two plates of the machine. And this gentleman's hand forearm got crushed between these two plates. So patient was received in emergency department of trauma center, and after an ATLS review, the patient was planned for below elbow amputation. But plastic surgery team was called to review for the available option. No. This is reference image, sir. And when plastic surgery team examined, these were the examination finding. As we can see that the forearm was completely crushed 5 centimeter from the elbow, including bone, muscle, nerves, even the skin, but the hand was relatively uninjured. So in such cases, the standard care of treatment would have been to discard the hand and to proceed with the below elbow amputation. After that, patient has to live with the prosthetic hand for rest of his life. Another option, if we wish to give functional forearm to the patient, would have been hand transplantation. But in that case, considering the young age of the patient and lifelong immunosuppressive therapy, this was a problem with the case, and that practice is not in current practice for unilateral hand. Now another option, if we wish to save the hand, then we would have to replant it to the elbow directly. That hand was separated from its forearm, that is its own family, due to devastating crush injury, and it was adopted by the leg, that is the foster family. Meanwhile, we reconstructed the forearm and we have transferred the hand to the forearm, like reuniting the hand with its own family. So how did we do it? So we have divided the whole journey into 3 stages. The first being hand salvage, and which include ectopic hand implantation. The second one was forearm reconstruction, which was taken after a month, and the final stage was hand transfer, which was on after 2 months of the index injury. So here we can see the first stage, that is ectopic hand replantation. This was taken in the ER department only, where we have connected the artery, vein and nerves of the hand to the leg. In stage 2, this was the most complex and longest stage of the surgery. In this stage, we have divided actually 4 steps. I'll come into later. We were intended to recreate the complete forearm
That is, we can see here that we intend to recreate the bone, vessels, nerve, muscles, as well as tendinous unit and the skin, for which we have taken two flaps, one from the thigh, one from the leg. So the step 1 of stage 2 was the stump preparation. We have done the debridement of leftover stump so that we can get idea about what length or dimension of the flaps and the skin will be requiring for the subsequent surgeries. The first muscle unit, was the composite fibular free flap, in which we have taken the bone, that is fibula, two muscle units, soleus and flexor hallucis, along with their nerves. The second muscle unit was the lateral thigh free flap, along with the vastus lateralis muscle, which included nerve vessels of vastus lateralis. The dimension of this flap was 20 into 5 centimeter, which was sufficient enough for extension of the newly transferred hand. So this was after the combining of the two flap. Here we have given function of flexion of the fingers, flexion of the thumb, and extension of the fingers. This is the newly reconstructed, newly recreated forearm, as we can see. In stage 3, that was contemplated after 2 months after the injury, when the stump was ready for the transfer of the hand. We have opened up the newly recreated stump and exposed the donor tendinous unit as well as nerves and vessels. The stage 3 was the preparation of the hand for the transfer. As we can see, the hand was separated from the leg with its neurovascular bundle. This is how it looked. The long skin segment with the blood vessels were taken with the hand from the leg. And this hand was transferred to the newly created forearm. The bony fixation was done with the fibula to the metacarpal. Also, the nerve vessels and the muscular tendinous unit were anastomosed at that time. Now, I would like to call Dr. Hitesh Gupta for discussion of the results. Please.
Good afternoon, everyone. I'll be discussing the results and the discussion part. So, before discussing the results, I would like to elaborate certain terms which were used in our procedure. So, reimplantation is referred to the surgical reattachment of a body part, such as a finger, hand, or a toe, that has been completely cut from the body. The goal of the reimplantation surgery is to reattach and restore the function to as much as of the injured part as possible. The topic reimplantation is temporary banking of the amputated part at the distant healthy site until the proximal stump is fit for the reimplantation. In literature, various donor locations have been reported, like groin, axilla, thigh, opposite forearm, dorsum of foot, and ankle. However, previously also the leg has been used for the donor side, but in our case, we use the external fixator such that the external fixator will prevent any inadvertent injuries to the amputated hand. Secondly, we have kept the metacarpophalangeal joint of the hand in the flexion position, which leads to the good range of motion. Thirdly, patient can also mobile with this reimplanted hand. Implantation and reimplantation. Sir, reimplantation and yes, sir. Free tissue transfer. When the tissue is detached from its blood supply and transferred to a different site with the re-establishment of the blood supply. While functioning free muscle transfer is when along with the blood supply, nerve innervation is also done to provide the function. Chimeric flap is when two flaps are raised based on a single blood supply. In our procedure, we have used these three techniques to achieve our goal. So, post-operative results, the forearm flap was healed well. The bone were united. Also, the donor side have been healed with the patient having a normal gait. So, patient has a total active range of motion in the hand of around 100 degree, with the index finger of 10 degree, middle finger of 45 degree, and little finger of 25 degree. and with a thumb with a 50 degree of total active movement, and with a grip strength of 2 pounds. Sensory recovery was achieved and in the distal part of the hand. In the gross motor function, patient was able to open and close the door with his forearm, was able to lift the heavy object, and he has a grasp for the large objects. Also, he can perform with the bimanual activities with his forearm. Again, the patient can use his forearm to drink water. Also, he can use his forearm to lift or heavy objects. Fine motor activities, patient was able to write his name and he was able to operate his mobile phone with ease. The reconstructed forearm looks similar to the normal forearm. So, comparison of the functional outcomes in past, various eminent surgeons have done the reimplantation of hand, but none of them has tried creating a new forearm and reimplanting the amputated hand into a forearm. The last case, Dr. Zhang in 2015 reported the dash score of 78, but in our case, the dash score was 21, which is pretty good. And the total active range of motion of fingers was less than 20 degree, and which in our case, which we have a 100 degree movement. And also in our case, patient has a key grasp, hook grasp, and he can perform daily activities in his hand. So achievements, this case has won the following prizes. It won the Presidential Pete Prize 2021 by the Association of Plastic Surgery of India. It's the best innovation case of 2021 awarded by the International Microsurgical Conference, and it is due for presentation in the World Society of Reconstructive Microsurgery for international best case in June 2022. So this journey won't be possible without our different specialties. So I would like to call Dr. Anesthesia faculty for the anesthesia challenges.
So I'm Dr. Sulagna. You will be fined an ice cream. Anyways, so our challenges, we had a lot of challenges because it was a long duration of surgery. We had to maintain throughout the fluid and the hemodynamics. The pain management was a bit tricky as there were multiple sites involved and there was a risk of bleeding due to heparinization. So many of our central urological techniques would not apply, and definitely temperature management. So we started our case with general anesthesia with endotracheal intubation. We did invasive monitoring. We had a very tight, we tried to maintain fluids on the lower side as it was a long duration, and we also wanted to minimize transfusion. So our pain management was with firstly brachial plexus block with local anesthetic like bupivacaine and an additive like clonidine. And the rest of it was maintained with fentanyl, intravenous, and morphine added with paracetamol. And later on, we did good infiltration of the lower extremity side. So we also prevented hypothermia, and finally we could extubate the patient after more than 12 hours of surgery. And the patient woke up conscious, alert, and pain-free. And we had no postoperative pulmonary complication even after more than 12 hours of mechanical ventilation. So we didn't do anything very novel, but our care was very intensive, and we are very happy to be part of this great case. Thank you.
I would now like to welcome our orthopedic colleague to present their challenges and their outcomes.
A very good afternoon to everyone. As we know, every pixel in an image is important to make it high definition and beautiful. Likewise, every department has done its 100% to make this possible. But from the orthopedic point of view, what I want to say is the bony fixation, all we see is bones. So what we had actually was a proximal 1/3 of forearm and an ectopic hand separately implanted in the leg. So what was our goal? Our goal was to make a fully functional hand, how much ever it was possible from our side. So we did a lot of discussions and planning which goes on to make it possible. In that we had which bone to fix, whether we should fix the radius which is left out or the ulna which is left out, or what should be our fixation method. Either we should use 1 plate or 2 plates, or what should be our plane of fixation. We should fix it from dorsally or ularly, and what should be the ideal hand position for him to have a good function overall. So for a building, for a glamorous building or a beautiful building, what you need is the strong pillars. And what we have tried here to create the strong pillar for the functionality of the patient to improve. Already in orthopedics, we already had a single bone forearm concept, wherein we use the left out ulna and for the elbow articulation and the radius for wrist articulation. We usually use it as a salvage procedure for recalcitrate pediatric pathologies or in the forearm tumors. And also we use it as a reconstructive procedure. Here we have used it as a reconstructive procedure, but what were the challenges we had? This was not the case we usually have. The difference was we had 2 units, the radius and ulna, which we had to tie together because the biceps, which is the main flexor, is attached to the radius, whereas the extensor, the triceps, is attached to the ulna. So we need to make it a single unit first to act it for the flexion and extension to happen. So what we did was the left out radius and ulna were tied together to make it as a single unit. That I have explained you. Then it is the glenohumeral joint which maintains the flexion and extension, which has to be strong. And as the concept here was to connect the left out ulna part to the make it a forearm one. So what we did is the vascular fibular graft, which was removed with a plastic surgery team. We used it to lengthen the ulna part by fixing it with a plate and giving absolute stability. That you can see in that pic, which is small. There we can see the plate also. Then what was the fixation method? Why did we use the plate? What were our other options we had? So other options we had was stent snelling, which you usually do in a pediatric forearm fractures or in an adult fractures. But the challenge here was it is a nail and we don't get a stability here. Because just imagine a cylinder and a nail inside it. It has a rotationally unstable. The cylinder can move here and there, and that gives a rotational instability. And already the biology is hampered because the forearm is not the forearm, it is the fibula. Already the biology is gone. We want it to be compression. We fixed it in a compression mode to get a primary union with the eccentric screws so that we can have a stable fixation and we can achieve union with minimum biology. So now you can see in the pic that the forearm has been created with the fibula. That now we have a neo forearm, the new forearm, which has to be fixed with the ectopic hand which we have. So what are the challenges now? So the main complication now when it comes to fixation of hand to neo forearm is the infection. Another one is the graft uptake. So straight away we didn't plan for going in for a dorsal plating because which can again cause infection. So what we did was initially for 2 to 3 weeks, we fixed with an external fixator or and a K-wire through the third metacarpal to capitate to fibula to temporarily fix it. Once we ruled out the infection and once the graft was uptaken well, then we planned to go for a dorsal plating wherein we have fixed the hand in the functional position, which is 10 to 15 degrees of dorsiflexion and a slight ulnar deviation to optimize hand grip strength. And how did we fuse it? How did we arthrodize the hand to the fibula? Is by decarticulating the cartilage and filling the gap by bone graft and then fusing it. So it was again 1 or 2 plates. We have definitely used 2 plates, but we have overlapped it so that the point of stresses are counteracted, and in the future you won't have a fracture there in between the plates due to a lesser fracture. So this is how the overall forearm with the hand was made. And I think we have made a good pillars and upon which they have built a very good building. Thank you. And now I would call Dr. Misha for physiotherapy challenges.
Thank you, sir. Good afternoon. I'm here to discuss the rehabilitation challenges. So the patient now has been under physiotherapy care for more than 2 years and 4 months since the time of his first surgery. So the first and the major challenge was to prevent the contractures and maintain the joint range of motion of the ectopic hand, for which we started the passive movement of all the PIPs, DIPs and MCP joints of hand and fingers. The patient's attendant was taught how to do the exercise and were asked to do after every 1 hour. Our second main challenge was to prevent the atrophy and maintain the neuromuscular junction. Here the new forearm was constructed, all the muscles were taken and new forearm muscles were constructed. The hand was placed after that in the neck surgery. So till the time there is a connection being formed, till the time there is a healing being going on, we had to maintain the muscle strength. For that we used the electrical stimulation. Intermittent galvanic stimulation was given for 15 minutes for each individual group, flexes of the finger, flexes of the thumb and extensions of the finger. Our third major challenge was ambulation of the patient. Since there was a hand placed on the leg, there was difficult and limited ambulation during that phase, which was almost 2 months. After that, during that 2 months phase, we started all the hip mobilization and knee mobilization activities. After the third surgery, we did the strengthening exercise, which was on the general physiotherapy principle of progressive resisted exercises. We started first the exercise in the bed, then in the sitting position, and then in the weight bearing positions. Gradually, we started with the resisted exercises. So after the third stage of the surgery, by 5 weeks, the patient was standing. Then single leg balance. By 8 weeks, patient was walking, and by 14 weeks, he was running independently under supervision. Another challenge was our COVID duration. During that, rehabilitation was difficult. We had a tele-rehabilitation. We did tele-rehabilitation weekly, and we had a total of 31 sessions through tele-rehab. During those sessions, we told the patient to do all the functional exercise for grasp and release, bilateral hand activities. He was encouraged to do the ADL activities with the simpler one first and gradually increasing the complexities. Then resisted exercise for the finger and the thumb flexion was started with half kg and gradually progressively increased the weight. Then the patient was asked to do the fine motor activities. Writing practice was given to the patient with a little modified grips. During these functional exercises, we have a difficulty because of the weak extension. Since flexors were good, the patient was able to grasp, but the release was difficult. Because of the difficult release, all the activities were hampered or delayed. For that, we had a followed up surgery that was adhesiolisis of extensors and thumb stabilization. After that, the patient grip has improved markedly and now is taken for recreational and occupational therapy training. That was the major physiotherapy challenges we faced. Thank you.
I would now like to invite our head of the department, plastic surgery, for some final.
Thank you. I think it was a very well executed and very well made plan. Having us give him a big round of applause for this. Night of the injury, he told me that, can we do ectopic placement? And I said, yes, go ahead and do ectopic placement. But then later we realized that we had something else in mind, and it was a total forearm reconstruction, which was never done before. And I must say that in this entire COVID thing, we had presented a similar case of bilateral leg replant. That also had a long COVID period of rehab in between, and it is very difficult for us to do the rehab part and the stages part. So, but luckily, this patient did very well, and we are now open for questions and comments.
So, I'm a layman in this. There's a single fibula in the arm. So, I mean, how do the metacarpals 5 are there? How do they become stable?
So all the metacarpals are united to the carpal joint. Our plan, although we are uniting the metacarpal to the fibula, the carpal joint is in between, which functions as a stabilizer for the other metacarpal. So although one metacarpal doesn't have a direct connection to the other metacarpals, they do have a connection between the carpal joints. Once we stabilize the third metacarpal, which is in the center of the head, the rest of the metacarpals are stabilized. And later on, we had to do something first CMC arthroplasty thumb also to stabilize it further.
Congratulations.
Thank you, sir.
I wish you would have shown us the video.
Yes.
So It's one question about the recovery of sense. That before
Yeah.
you
So to cut short the reinnervation time, we had done again something new. So when we had transferred the hand to the leg, we had connected one of the sensory branches, the saphenous nerve, to the median nerve. So in that way, the hand started having its reinnervation re-established through the saphenous nerve. And when we took the hand back to the forearm, we took a long graft that you had seen in the picture. That was the saphenous nerve, which was then connected to the proximal stump of the median nerve. Although the nerve will still take that 1 millimeter per day time to get all the way to the hand, but that is acceptable because at the end of 1 year, we'll be able to get visualization in the hand. Yes, correct, sir. A sensory hand is all very important, and we took care of that with the transfers. All the reinnervated muscles are MRC grade 4. Grade 4 is acceptable power for performing most of the functions. And in the video, unfortunately, we are not able to play, but you can see the good range of motion that we were able to achieve. No. So if the muscles are reinnervated, they don't usually lose the power if the patient is continuously using them for any daily activity. The muscles will retain their power if the patient is using them. Yeah, so we are like our physical therapy team is actively promoting so that the patient is vocationally rehabilitated as well. Start using the limb for his day-to-day activities and for his occupation. Thank you, everyone. Thank you.